the woman, the myth, the legend, Karen Parker Davidson, Dr. Karen Parker Davidson. So awesome to finally be able to have this podcast with you and be able to share this moment and have this conversation. So welcome to the podcast. We're excited to have you here. Give us a little bit of, you're welcome.
Thank you for having me. This is a pleasure. Quite a pleasure.
Yeah, we're super stoked to be in your home and to be able to have this conversation, to be able to talk about everything nasal breathing and so much more, of course. So I'd love to learn a little bit more about you. And of course, I'm sure our audience wants to hear about it as well.
So let's get nosy.
Let's get nosy. I love that.
Let's get nosy. So this journey began back in 1991 when I worked in the recovery room thinking I wanted to be a nurse anesthetist. Well, if you know me, and you do, I don't sit still for very long. So I ended up in the recovery room, graduated from UNC Chapel Hill School of Nursing, went down to Charleston, South Carolina, and was their first new ever graduate nurse.
Wow.
In the recovery room. Yeah. Did that for a few years. Got my commission in the Air Force Reserves as a flight nurse.
Okay.
It's a little bit more air influence.
Yeah, I see what you're doing there.
Then I started nurse practitioner school in 1995. Did a little bit of a change into business. Thought it'd be really cool to work in the OR as a vendor. Went into that world in 1997 and then really went back into my OR days. So while at MUSC, it was great because we had to get our CCRN, which was the Critical Care Registered Nurse certification, and a lot of airway. And so in the recovery room, we are so used to airway, emergencies. You go from the foot of the bed to the head like that. So it was always kind of an intriguing thing for me. But fast forward, took all those OR days and experience into the vendor world, specifically the ENT world in 2002. Did a vagus nerve stimulator product for a year, and then went into ENT for about, in some degree, for 10 years. So that was a great opportunity because I got to see over 8,000 ENT cases, either in the office or the OR.
Sorry, what does ENT stand for again? Just so.
Ear, nose, and throat surgeon.
Got it.
Otolaryngology.
Perfect. Okay.
So got to see over 8,000 cases. But it wasn't until 2017 when I came on board with GM Instruments as their contracted VP to realize that the airway function and flow weren't being measured. So it was a huge aha moment. And that was the trajectory to where I am today.
Wonderful. Wow. Thank you so much for sharing that. It's quite a journey. Yeah. So with all those experiences, you now are also working as an entrepreneur for yourself. You're also teaching classes.
Gosh, yeah. So I teach at two universities as adjunct professor at Liberty University, and I teach health policy at the master's level. Just got done writing the doctoral course for health policy at that level. Also do dissertation chair positions, helping students get to that doctor status, and help different companies, talk about airway function. So I have done some proprietary work.
Okay.
I carry a lot of copyrights, a few patents in review, and created a Maverick nasal exam, a fact healthcare, kind of a fact proprietary method as to how do I look at the nose? Because I still see patients on the weekends. They'll come to my office to do rhinomanometry, and I look at flow, function, and rhinomanometry is a technology. It's been around for a long time.
Yeah, why don't we talk about that?
Yeah, it's transitioned over the years. So there was a basic, rhinomanometer that was around since 1992. Actually, it goes back to the 1960s, and the whole concept of rhinomanometry has been around since like 1894, 1895. But it really transpired and developed over the years.
Right. So at a fundamental level, what is rhinomanometry? Jeez, that's a tongue twister.
So rhinomanometry, it developed into 4-phase rhinomanometry. So we look at 4 phases of breathing in one respiratory cycle. There's so much information and data that you can see in that. And the computerized version was developed by Dr. Klaus Vaught.
Okay.
And so he's an ENT, a dentist, and an oral maxillofacial surgeon. And he was so frustrated by what the patients were telling him after sinus surgery. They would say, yeah, I can breathe well. But he was seeing and perceiving something different. So he created that. Now, a fun fact is that he created this to look at the nasal flow. So our inspiratory flow is so key. That is the driving force behind how we breathe. But it also plays a role in oral health, dentistry and so on and so forth. And that's why I'm now teaching orthodontists and dentists, that you have to look at the flow and function, because air will, like water, air will follow the path of least resistance.
Right.
We have to survive. And if we don't get enough air in, we begin to compensate.
So if you're not getting enough air through, let's say, naturally your nose because of a deviated septum or a nasal valve collapse, you're probably going to be focusing more on mouth breathing, right? And so that's,
So when we look at breathing, nasal performance, just on breathing in through the nose, nasal performance is 1.2 times higher than when we breathe out. So we do a lot more work when we breathe in. So when we do rhinomanometry, we're looking at the flow, limitations, and the amount of pressure in the nose, because we already have pressure in there, which will give us the amount of resistance. And that resistance is the key denominator and driver to sleep apnea and how well we function and how well the nose functions. So when you look at the studies, you can see where BMI, body mass index, and nasal resistance, or you'll hear it as NAR, N-A-R, are the two predisposing factors for sleep apnea. So Dr. Vaught and our work, again, rhinomanometry, we're looking at flow and function. It's measuring the amount of resistance. But in my discoveries over the past few years, I began to see some really neat things. So back around 2014, Dr. Vaught saw this really crazy phenomenon. When we do rhinomanometry, we have a mask. We plug one side of the nose. We capture the flow on the other side. We measure it against a pressure gradient, and there's international standards on this. So it's not pseudoscience, it's not black magic or anything crazy.
Right.
It's documented in over 2,000 papers. And there's an international, international society that looked at these of what is normal in objective measurements. So what Dr. Vaught found is that it's called a nasal valve phenomenon. Not a collapse, but a phenomenon.
Right.
You can't see it with the naked eye. So if I were to look at you, I wouldn't know if you had a nasal valve phenomenon or not. But when I hook you up to a rhinomanometer and I see a loop, it could be a mild loop, a moderate loop, or a severe loop. Well, what does that mean?
Right.
So a nasal valve phenomenon means that that's going to dictate how air gets into your nose. And there's a principle that we use called Bernoulli's principle.
Okay, let's talk about
It's
that.
a little physics 101. So Bernoulli's principle, it's a really neat concept. It looks at the velocity and the size of the area or a tube that's trying to, have the activity of the air coming in. What's really neat, and back in the 90s, I became a certified registered nurse infusionist. So I left a little bit of the PACU and did some home health and went to home infusion therapy. Bernoulli's principle is based on the velocity of fluid. Well, fluid's kind of like air, right? And so we found that when you look at the nose, 80% of our airflow to the lungs comes through the nose. Then you look at upper air resistance. And that's something that a lot of people in the sleep world talk about. They talk about, upper air resistance.
Okay.
You can't really see it on a sleep study. But it does happen. It's kind of like a pre-OSA. That's how I define it. The industry might say something different. But that upper air resistance, over 50% of resistance occurs in the nose. Think about that. And that's why I call the nose its own little organ. It is so complex. And I have a book coming out next year called The Nose Decoded.
Okay.
It literally has 60 functions.
Wow.
Now, Dr. Maurice Cottle maneuver, he said there's 30. Sorry, Doc, I came up with 60. I really drilled down. So I broke that down into I broke it down into 5 categories, and we now have 60. I could have been a little crazier and probably come up with more, but a simple function like it holds your glasses. Holds your glasses on your face.
That is true. So there's probably external and internal functions, right? There's
absolutely. So when we look at the nose, like I said, it's so complex. It's its own little organ. It's a reactive organ. It reacts to our nervous system. It reacts to our sleep. It reacts to our awake state. It reacts to allergies. So it's really phenomenal. But when we looked at these nasal valve phenomenons, we were finding that there's some way Air is following the path of least resistance. It's looping around the nasal valves, and that's affecting your oxygen uptake and your oxygen intake. How efficiently is your body working based on the amount of oxygen it gets?
Right.
Pretty cool, huh?
Yeah, I mean, that's fascinating. And I know a little bit about that word intake, by the way. It's one of the reasons
Intake.
why we're here, right?
Yeah, exactly.
But we can talk about that later for sure.
But so the nasal valve phenomenon is different than a nasal valve collapse. And we can see a collapse. I mean, it's why we're here with intake.
Yeah, it's pretty obvious.
And that collapse can really do a lot of damage on breathing, sleep, exercise, athletic performance. And I think that's my driving force, is to really, after studying rhinomanometry for 7.5 years and studying the science, and Dr. Vaught and I'll give him a plug because he's amazing. We're pretty much the only two people in the world that really know what this logarithmic flow that we capture through a device is really what it means.
Deciphering it.
Yeah. And so through all of my work and new discoveries, I can see the stability of a tongue. You know, is the tongue getting pulled back into the throat when we breathe? So
which is an indicator of snoring, right? Or
absolutely. Yeah. If you have a weak tongue, and you see a lot of conversation about tongue tie releases. So I can see a failed tongue tie release because we're negative pressure breathers. And when we breathe, and if that tongue is floppy, for lack of a better term, if it's floppy and it's not strong enough, it will get sucked back into the back of the throat.
And not even based on gravity, just based on lack of muscle.
I mean, sitting in my office, I can see it in the awake state. Wow. And we have to understand that a daytime nose is different than a sleepy time nose.
So it really is phenomenal. Like it's evolving, it's dynamic.
Yeah.
It's changing all the time based on its environment and what's happening around you.
Exactly.
Fascinating.
And so when you look at just the whole function and whatnot, now I can even see the breathing patterns on rhinomanometry. If I see, now when we look at rhinomanometry, there are numbers at the bottom of the graph. And there's a graph with tracings, color tracings. And we can see, does the tracing on the graph match the numbers in the box?
Right.
Now I can see the breathing pattern. And what's really, really neat now is that we're doing more work with veterans with PTSD.
Okay.
Now, if I get a little emotional, I apologize because that's just such a passion of mine.
I love that. Because
75%, and I'll put me inclusive because I am military, but 75% of us have some form of PTSD. Is it from war? Is it from a situation that happened? And we don't know. It can sneak up on us. I mean, it happened to me. I froze at a baseball game, and this one colonel looked at me. He's like, "Are you okay?" And it was a low-flying plane. Why would a low-flying plane make me freeze? Well, I went back to 9/11 and being deployed, and the planes going around at night. So even our nervous system, even our mental health is so affected by how we breathe.
Right. I mean, I feel like, so my daughter and I, we play, disc golf together, and we play a lot of sports together, and we're pretty involved. And one of the things that we talk about all the time is, especially even walking up a hill, right? Like you kind of lose your breath. You have to catch your breath. And so taking that time to reset before you throw your next shot, or let's say you're playing basketball, there's a timeout. Take that time, right, to really focus in on your breathing so that you can close your mouth, take deep breaths through your nose, exhale slowly. These are things that we've all been kind of, we've heard and talked about throughout just experiencing life. But I think sometimes we forget the importance of that. That is literally what is allowing us to function at our best capacity levels, right? So if we're breathing in a way that allows us to perform, then we're putting ourselves in a position to succeed, whether that's even in a physical sport, a mental activity that we're doing, right? So it is really fascinating, and I feel like it's something that we overlook so often, just because it's I don't know, I don't think about my nose that often, you know what I mean? there's so many other stimuli that I'm looking at, that I'm thinking about, and the nose is kind of one of those things. It's happening. What's that, autonomously or subconsciously or
all of the above? I mean, that's why my handle I created was the nose knows.
Touche.
The nose really knows.
Yeah.
And you talk about athletics, so let's talk about that for a minute.
Sure.
And this is a pet peeve of mine, because if we look at the whole sleep and breathing world, they emphasize so much of it on sleep. But that's 1/3 of our day. How about those other 2/3 of the
Yeah.
day? We don't walk around with a CPAP during the day. We only use it at night.
Right.
But how's that nose working during the day? And that's what's really interesting. And that's why we have to quantify the actual function and the flow. What's coming in to help us perform? And in athletics, they really focus on sleep. But guess what? Nasal dysfunction will occur long before you have a sleep problem. And I'll say that again. Nasal dysfunction
That's so good.
will happen way far in advance before you have a sleep problem. And I have a graph where it shows we have a flow limitation, air through the nose, that creates more pressure built up in the back of the throat. And what's the emergency escape route for us? The mouth.
Right.
The mouth opens. Your oxygen drops. You become hypoxic and you gasp for air. So when the athlete, it was really interesting. I had a doctor from Florida call, and he said, "What do you know about pitchers?" What do I know about pitchers?
I mean, they pour water, right?
Yeah.
Sorry, I went down to 4.
Right.
I had to.
So he put me in contact with an MLB director of athletic performance. And I worked with their trainers to show them how nasal breathing with their pitchers. And I did this whole examination on 5 of them.
Okay.
All 5 were mouth breathers, and they could not hit the strike zone. It was thrown in the dirt, and so on and so forth. And so then they use the Whoop app for sleep to kind of see how they're gauging. And I sat with one of the athletic trainers, and I was going through the Whoop tracing, and I could pinpoint where the HRV dropped is where they were most congested. So I could see where a player was getting sick or had allergy issues.
Wow.
And that's really impactful because
All through the measurement of a nose reading, or
so when I see high nasal resistance
Yeah.
on rhinomanometry,
Yeah.
I know that there is a low heart rate variability. And you'll hear it HRV. But that HRV is so important because when you look at athletics, that heart rate variability is kind of a determining factor as how you're going to respond to stimuli, how you're going to hit, how you're going to pitch. So when Zach, my son, was a catcher, I always knew when he was congested. The kid hardly ever strikes out. His best pop time was 1.84. And a pop time is the amount of time that the catcher grabs the ball and throws it to second base for an out. Well, the average is like, in the MLB is like 1.88, and he threw about a 1.84. But when we would go...
as a teenager.
As a teenager, he was 17.
That's wild.
Yeah. And so we go to Alabama for this big, world wood bat tournament. He struck out twice in a game. His pop time was so off. And he has allergic rhinitis. So he does have breathing issues according to an environment. And I started using different techniques to get him breathing better. But my point is that he didn't have the amount of nasal function in Alabama in June like he did in May during the regional tournament where he hit 5 RBIs in one game. He had a triple, a double, and a single, and 5 RBIs in one championship game or regional tournament game for his high school. And just a month later, he couldn't hit the ball to save his soul because he couldn't breathe.
Yeah. So not everybody obviously has the benefit of having Dr. Karen Parker Davidson as their mother and travel mate and all those amazing things that you are for your son, Zach. So let's broaden the topic a little bit. If you're an athlete that is maybe struggling with performance and you're aware that your performance can be related to your nasal breathing or breathing in general, what's something that maybe, like you said, you had some techniques that you were using on Zach to help him breathe better. What are some of these things that people can do for themselves if they don't have the assistance of a KPD, if you will?
Well, so the first thing I tell anybody is the story is in your nostrils. And they're like, what? The story is in your nostrils. And when I do nasal exams, I look at people to kind of evaluate what I'm going to see. So I look at someone's face, and I can literally tell you within 30 seconds what side of your face will have more resistance, nasal resistance. And remember that nasal resistance is very slow, it's very sneaky, it's very insidious, and it's cumulative like a concussion. Same thing with a concussion. People that have concussions have breathing problems.
Right.
Because of where the brainstem, has our respiratory centers and the amount of impact. And trauma, we used to call it a coup, contra coup. So the coup is your head going forward, and the contra coup is your head going back. Now, when you look at the respiratory center and where they are on the brainstem, and how when you hit your head, the impact it has on the brainstem, now over time, that gets cumulative and you have a breathing disorder. So basically, I look at someone's face, but I also look at their posture. So if you have high resistance on one side, then the opposite side of your body will have a posture problem. So I had a lady come to my office, had sinus surgery, had dental work, so on and so forth, and she still couldn't breathe. So I did a rhinomanometry, and based on that and based on my Daphne software, it showed me she was predisposed to moderate sleep apnea. Well, long and behold, she had a test, and it was moderate sleep apnea. So I had her stand in the hallway of my office, and I was talking to her, asking her about allergies, asking her, have you changed your bed pillows recently? And as I was talking to her, she had high resistance on the left side. Her body began to tilt to the right. So things you can do at home. Look at your nostrils.
Right.
Are your nostrils equal and symmetrical in size? Then I always look at like the spine of the septum is here. That's a columella.
Okay.
And so I have people tilt their head back and I look at the columella to see, is it going one way or the other way? Because over time, when you can't breathe, you will have facial changes. You'll also have palatal changes. So your palate will almost become like a little teepee tent.
Sure.
Well, what does that do? It impacts the septum, which is the wall of the nose that divides the right and left. And what do you end up with? A deviated septum. And when you see people with sleep apnea over time, they will have a really bad deviated septum. I saw that in my dad. He was a mouth breather. And as the more you mouth breathe, the more the oral cavity will change, the more your nose will change. And so I think in the medical world, that's what I learned in nurse practitioner school, is that the medical world was, do your exam, create a diagnosis, and give it a pill. And if you do a test, the test has to be resolved with a pill. So we need to get beyond that. So to your question, what do I do? When I see someone with irregular nasal structure, I'm very conservative. I will go with nasal dilators, so I do intake. But I also do a decongestion test. We call it a nasal provocation test. And I do that to see how much the mucosa will decrease. So I do a baseline rhinomanometry, then I'll spray, a decongestant, not Afrin, but I'll do a decongestant test with a homeopathic over-the-counter product, and I wait 10 minutes because that's the American Academy of Allergy, Asthma, and Immunology guidelines. We spray, we wait 10 minutes, and then we'll retest. And I can see how much did the airway open, how much did the resistance drop, and based on that, I'll do a nasal dilator, and I like the external ones over internal for several reasons. But I use intake, and then I'll use the homeopathic spray, and I want people to do that for about a month. Now, if it's a huge collapse, then I pull an ENT and say, could we do a nasal valve implant? Could we do like a radio frequency type procedure? And there's many ways to fix it. But I always like to start very conservatively because an inflamed nose is a sign of an inflamed body. I mean, think about that. An inflamed nose is a sign of an inflamed body. Well, why? Because the nasal mucosa is sympathetically driven. It's like a fight or flight. We got to calm that down.
Right.
And once you calm that down and once you calm the inflammation down, and there's even research out there that in children, if you did expansion on a child and open up the airway and calming them down, you don't have to take the tonsils out.
Yeah. That's incredible.
So I'll tell you, the one thing I do like about intake, there's a product that we used to use in ENT world. I used to sell it. It was called a Denver splint. And the Denver splint was foam beneath, and it had a metal shell. So it's very malleable. And we used to use those a lot with rhinoplasties or sinus surgeries. So when I saw the intake, I'm like, that looks like a modified Denver splint. And it's very stable. And that's what you want. You want enough pressure on those lateral nasal walls to create stability in your breathing.
Right. All right, let's talk about intake breathing. We're so grateful to have you as a clinical advisor here on the team, and that's one of the reasons why we're here, and we're so honored to be able to just take all this knowledge from you and apply it to all the things that we do, whether it's through marketing campaigns and the way we even just educate our audience and also ourselves, right? The more we know about the nose, the better we can serve our customers.
Right.
And so that's what makes this really exciting. I'd love to get your backstory on how you even discovered intake. Did intake come to you? Because this was before my time. But did intake come to you? Did you come to intake? Did you see us in an ad somewhere? How did this all happen?
Gosh, so through Instagram, I think it was Instagram. To be honest, I can't remember.
Okay.
I saw
I'll have
it
to go
somewhere.
back in the DMs and check it out.
I saw it somewhere. But I will tell you, I've been part of, nasal breathing strips, wink, wink, nasal breathing strip studies as far back as 1997. And they used rhinomanometry in some of the studies, and acoustic rhinometry to see, was the volume bigger? Did it help you breathe better? And I must have seen it somewhere on Instagram. I don't remember. But I looked at it, I'm like, that's it. That's it. So I Googled. I Googled and I stalked intake.
Thank you for that.
But I was looking at the product and I became passionate about it because in February of this year, Dr. Vaught and I and 3 other of our colleagues from the ENT Airway Lab in Germany and Latvia, we looked at elastometry. We looked at the lateral nasal walls of the nose. And I always wondered why the strips would pop off. They're malleable. Is it an adhesive problem or what's going on? And I felt like when I saw that, I'm like, that's the Denver splint.
Yeah.
That's it. So when I saw it, I was very intrigued. But the most intriguing part of it was the several sizes. Well, why does that matter? Because if you go back to my conversation about nasal phenomena, nasal collapses, there is variations of each one. But how do you to have a one size fit all is really hard to do, because what you need is not what I need as far as how much pressure do we have to put on the outside of the nose to pop it open and really have impact. Remember, the object here is to get flow in the nose.
Right. And there's a such thing as too much flow, right? There's like an ideal level of flow.
Yeah, so there is. I mean, it's always going to have a lot of flow, but it's the resistance. That's the key denominator when it comes to how the nose is functioning. I mean, I zero in on inspiratory resistance, precisely, inspiratory resistance. How well is air getting into the nose? Because if you look at it, I've heard on podcasts and on Instagram, I've heard, you should breathe nice and quiet and slow without resistance. Well, when I hear without resistance, that just sends me over the edge because that's false. We need a little bit of resistance in our nose to slow the air down because we have little hairs in our nose called cilia that do the filtering.
Yes.
We want the air to get warm and humidified to get to the lungs, because if you send cold air to the lungs, they expand.
All of a sudden, I'm remembering everything I learned in 7th grade.
It's
this
CPR.
Is fantastic.
CPR 201.
Yeah.
So we need a little bit of resistance. There is a normal range of resistance. And I get that question a lot. What's normal? Well, I can't tell you because that's part of my patent. but
yeah, and normal's probably different for everybody, right? What's normal maybe for a 6'7" person?
Yes.
Yeah, I mean even size, right?
Yeah, and so if you have too many like sinus surgery, like turbinate surgeries, which there's a lot of them, you can get what's called empty nose syndrome.
Never heard of that.
Yeah,
Empty nose syndrome?
Yeah, so the air's coming in too fast and you feel it doesn't slow down.
Okay, is that what happens when I like get all the nose hairs out of my nose and then I just can like breathe in really fast and easy?
No,
Okay.
not quite like
so I
that.
can still keep trimming my nose hair.
You can still carefully.
Okay.
But what's interesting is when I sold a sinus drill, my number one sinus blade that I sold was a 2.9 millimeter Terminate blade. I mean, there were so many Terminate surgeries because when you look at allergies, that's kind of like the first pit stop of resistance and a histamine reaction or an allergic reaction, and then everything kind of swells up to react against that allergen. But if you have too many Terminate surgeries, and it's I don't know how common it is now, but it does happen. But it's called empty nose syndrome.
Yeah, I haven't heard of it.
And so the air is coming in so fast, you don't feel like you're breathing well through your nose. And and a lot of the patients with empty nose syndrome or ENS, they're told that, it's a psychiatric thing. They get very anxious.
Interesting. Because they're getting in so much air
it's
through
like
the nose.
you can't feel like you're breathing. Right?
Interesting. So is it almost comparable to like when you're riding like a motorcycle or something without a windshield and you're just getting in so much you can't even breathe like that? Or
no, this is more of you like you.
But you know what I'm talking about, though, right?
Yeah.
Like where you're just going so fast and so much air is coming, and you're like, okay, this is weird. Like
kinda, yeah. I guess kinda, maybe.
Probably less, like more subtle, probably.
But they become like a positive pressure breather, and we're not toads on a lily pad. We're like grasping for air. It's a quite unusual phenomenon. Now, one of my doctors that I work with and have trained in rhinomanometry, Dr. Nyack at Stanford, he has a really awesome surgical procedure that he uses for those types of patients. Now, I'm not sure how it looks on rhinomanometry. I haven't gotten any feedback back, but it's a quite interesting phenomenon. But a lot of people say, oh, you've got a mental health problem or an anxiety problem. No, it really does happen. And
this is just because of too many surgeries.
Too much air coming in too fast.
But too many surgeries. Naturally, you don't find people like this, right?
Yeah, I mean, usually it's from a turbinate surgery.
Okay, yeah. So it's post-op something. It's not like Jimmy was born this way and now he has this situation that he's dealing with.
We can always find different anomalies. It's really interesting to bring up children.
Yeah.
That's my passion, children. And that's kind of the path to intake that brought me here, is that I'm in a lot of moms groups. So I see intake on Instagram, wondering, this is really, really cool. Reminds me of the Denver Splint, which was a great product, again, to keep the nose stable. And that's the thing, we want to keep the nose stable. Now, I've done a lot of work with the Breathe Right strip, because they used our equipment for their studies.
Sure. And Breathe Right was there before intake was. Right?
Yeah, Breathe Right's been around for, decades. I want to say, decades.
Yeah.
But it didn't do enough. So I see intake on Instagram and my curiosity, flares just went up. This is really cool.
Yeah.
Now, why is that important? Because in February, Dr. Vaught and our three friends, we have 3 ENT airway labs. We do all this, science-y things and what works and how can we trick the airflow. So we're nose nerds. But
you don't say.
We're nose nerds. And what was really interesting is that we did a paper and we were the first in the world to create an instrument to look at the elastometry of the lateral nasal walls. Well, elastometry is, just as it sounds, the elasticity in the lateral nasal walls.
Can you show me on your nose where are the lateral nasal walls?
We're talking the outside of the nose.
Okay. And is it higher? Is it lower? Where are these walls?
It's the whole sides of the walls.
Okay, so everything left and right of the nose.
What we measure was right here. We look at the alar area right here. So we were curious to know, what is the impact of the lateral nasal walls? And with intake, it makes a big difference. What I found interesting is there were 6 different sizes. So then my next scientific answer is, well, how much pressure is exerted on the lateral nasal walls, size by size by size. So I'm getting these DM messages in, and all the moms are using Breathe Right strip, and I was like, I got something better. Ooh. So I contacted Alex at Intake, and I said, I need a baby take. I need a baby intake because these kids can't breathe. And the moms are looking for something, and they're frustrated with flexible, malleable type of splints.
Now, when we say kids, are we talking like 3 to 6 months, the first year of life? Or are we more like
No.
3 to 6 years,
3,
7-year-olds?
4, 5, 6 years
Okay.
old, yeah. And I've done
So
work on
kindergarten, first grade.
yeah, and I've done work. So there was Dr. Patrick Burns at Johns Hopkins. I was helping him and working with him, looking at the efficacy of a nasal cone. So there's internal nasal dilators, and then there's external nasal dilators, and they all have a position. They all have a place in the market.
Okay.
But scientifically, when I look at it, when you put a foreign body in your body, what happens? It'll kind
creates
of
a
reject
blockage.
it, and
Yeah.
and it kind of gets inflamed. Like, what is that? But again, when you go back to the nasal airflow, 50% of upper airway resistance in the nose, and the highest point of resistance is in the first 1 inch of your nose. So right here, where you have your intake.
Absolutely.
That is just so key. And if this first 1 inch of your nose doesn't work, myofunctional therapy, surgery, breath work, all of these different things on the market are not going to work.
It's like it's dammed up or something,
A
right?
dysfunctional nose will not react well without intervention. So I contacted Intake and said, this is phenomenal. I'd like some samples, please. And actually it was in April, because my curiosity got me to thinking, well, what would this do for Zach? What would it do for somebody who doesn't have a nasal valve collapse? Will it work on them as well? So in April, I did a study, just a case report that's going under peer review for publication. And what's really interesting is that the strength of the size of the intake band was varied on what it did to the air coming in the nose. So for example, Zach doesn't have a nasal valve collapse. He doesn't have a nasal valve phenomenon, but he has allergic rhinitis. So with him, his baseline rhinomanometry was beautiful, except for the congestion on the left side, which we knew.
Right.
What was interesting when I put intake on him, I did all the different sizes. It was the M2 that was perfect, where the smaller sizes increased his nasal resistance. So it really manipulated the nasal valve area to make the air struggle to get in to increase the resistance. But when I put the right size on him, the M2, the resistance dropped. So I sent him outside into the batting cage in our backyard. And I said, okay, go out there and I'll do a baseline on you just like we did. And I'm going to compare it to a Breathe Right strip. The Breathe Right strip had hardly any impact on nasal resistance, meaning it did not impact the airflow like the intake did. Fast forward into May, I did an entire baseball team and looked to see, how visible collapse did it really work. And it dramatically reduced the resistance in these boys.
Surprise, surprise.
Exactly. So when we look at, when I look at intake as a science, the size of the band has to match the need. So somebody may say, well, I'm just going to put that on my nose. Well, you might have a little bit of a reverse effect.
Right.
So we had this conversation in June. And in June, a lot of people do what's called the Cottle maneuver. Now that's from Dr. Maurice Cottle. And so you put your fingers on it's on Instagram, right?
Yeah, on our homepage.
Exactly. So you put your fingers on your cheeks and you just, spread the skin outward to see right here, do you feel better breathing here?
Mm-hmm. Does it feel more open, right?
Yeah.
Yeah.
Can you breathe better?
Yeah.
So talk about the sizing.
Yeah.
When you look at intake, each size has a little bit more pressure that's pulled on the sides of the nose.
So size does matter.
Size matters. Pressure matters.
Okay.
Pressure how we breathe, nasal resistance, pressure on the amount of, pressure you're exerting on those lateral nasal walls.
Right.
So somebody with really bad nasal valve collapse, and they don't want to have surgery yet, you really want to make sure that the side that's the smallest size really opens well. because I see a lot of reels,
Mm-hmm.
and of course I go right to the nose. I want to see those nostrils.
Yeah.
Show me
Yeah.
your nostrils.
Give us the
Show me your nostrils.
viral shot.
Yeah, show me your nostrils. That should be a catchphrase, right? Show me your
You know,
nostrils.
you're definitely gonna catch some people off guard with that for sure. You're on a first date. I want to see those nostrils. I don't know if this is gonna work or not, right?
It's rather scary, but if I'm standing at Starbucks in the coffee line, I'm looking at your nose. And I'm trying to see your nostrils.
Make sure you
Because
blow
I
your
just
nose
wanna
around.
fix it.
Make sure you're always blowing your nose around KPD.
Yeah.
Otherwise, she's gonna call you out.
But that size really doesn't matter because it looks at how much pressure
Right.
we are putting on the sides of the nose to make it open. But the key thing is you really want to make sure that when you're opening the nostrils and the nose, because the studies show volume of the nose does not equate to the function of the nose. And you have to remember nasal resistance, which is like what we have to slow the air down.
Yeah.
If we have too much resistance, that's going to have a reverse effect and things may not work. So it's
Right.
really that driving force.
And people turn to mouth breathing more when they have more resistance.
Exactly.
Right.
So at each level of resistance, we know if someone's going to respond to CPAP. We know if they do surgery, what change we should see in nasal resistance as far as dropping. Oral appliances, is the oral appliance working? How much movement do you have in the mandible? So someone might do intake with those online mandibular advancement devices or MAD and think, well, if I push the mandible out to open my throat and I open my nose, I'm going to breathe really well. Well, not really, because you might just need the intake and a homeopathic nasal spray. But that MAD could have a reverse effect, and it's in the science. It's in the science already. Yeah. So to your point, you really have the trial size is phenomenal because people can see what feels better. Now, we have to remember, too, that there's a principle called Weber-Fechner law.
Interesting.
I'm going to make everybody a physicist by the end of this podcast.
Yeah, you are.
By the end of this session, Physics 101. In our airway world, it's called the Weber-Fechner law. The Weber-Fechner law is the psychophysics of breathing. So it's looking at how we respond to a stimuli. And that's very subjective. People say, I breathe well, I breathe great. But then they
how's
come
that
to
measured,
me.
right? Exactly.
Yeah, they come to me, and it's a different story.
So real quick on the, sorry to interrupt you, but
Yeah,
with the
go ahead.
sizing, right? So like, again, not everybody has a rhinometer at home and they can't really measure their own flow and resistance and all that, all
Right.
those amazing things. We have our own guide for what the appropriate size is for your nose.
Yeah.
But how would you recommend that somebody who buys intake for the first time wants to go to bed with it on? How do they determine their sizing from from a medical perspective and from a medical understanding?
I like how you promote to take the band. Let's try it. Let's put this one on me. How about that? Let's try it.
Perfect.
So this is what we have in the box.
Right.
And if you go and you look at it's called the alar width, nostril to nostril. So this area
Right.
here.
And the exterior
Correct.
side of the nostril,
From
right?
this side,
Yeah,
the
yeah.
outside of the nose to this side, the outside. And you want to look, does this fit? Yes, it does.
Okay.
And then you want to test what feels better. So we want to look at where do we put the tabs?
Mm.
And again, coddle maneuver up here. Does this feel better? Pretty good. Or does a Davidson maneuver? Does this feel better? So
Right.
the internal, the external. Now, for me personally, I use the M1, but I don't have a nasal valve collapse.
Mm-hmm.
I don't even have a nasal valve phenomenon. But if I'm congested and I don't want inflammation, remember, an inflamed nose is the sign of an inflamed body.
Right.
So if I'm congested, I go right to the N1. And the external area is better for me than the internal nasal valve level. So I place my tabs a little bit more forward towards the tip of my nose. And then I take the dilator and I will put it more towards the tip of my nose. So I have more pressure here than I do up here.
Right.
And that's so important because we can get a little lazy. I've watched my patients do it and said, try this. Demonstrate to me how you're going to do this at home. I give them a sample. And when I teach them in the office and I watch where they put that tab, because there's also a curved portion of the tab. So is that going in the right direction?
Right.
So I have them, show me how you're going to do this at home.
Yeah, because application is key, right? I mean, even as something as simple as making sure that your nose is really clean and dry before putting it on, because you could think, well, I bought this magnetic intake thing and it's supposed to change my life according to all these Instagram reels and TikTok reels that I've seen, all those people reacting to this thing. And then you go and you don't thoroughly wash your nose, or you don't put the tabs on in a place where they're going to actually stick to your nose, right? So one of the keys to success with even wearing intake is making sure that you're following all the steps accurately, right? And that aligns with sizing too. Like that's part of a step to making sure that you have an experience that is designed for you.
I shared this story the other night. It's kind of cool, but I was a little congested and I was in my office working on another book and I just felt congested. So I put the M2, I put the intake on in my office and I put the tabs, with the curvature side towards the nose, put the M2 on, and I sat there and I just took a nice slow breath in through my nose. And it felt like Rice Krispies going off in my nose. And I thought, wait a minute. Now, what's really neat in my research, and this is true, there was a question about the magnets. What impact do the magnets have on the nose? Well, we have a little bit, there's devices that we, do implants in the brain that have a, magnetic component. Like the cochlear implant, it has a magnetic component to it.
Don't we have like every element of the earth in our body to a certain extent?
So we have, believe it or not, we have a little bit of magnetic activity in our nose.
Okay, interesting.
So in our sinuses and even in our brain tissue, we have magnetite. And magnetite is also found in birds. That's how they're able to migrate according to the electrical fields, the electrical magnetic fields. So I put on the intake and I felt my nose kind of like snap, crackle, pop. And the first thing that came to my mind was the magnetic fields are working in my nose. And they just opened up.
Yeah.
It was amazing. It was rather wild. So I put a message out to the group and they probably thought I was crazy, but it's really true. And so I'm wondering now, my science brain is, what effect does intake have on the little pieces of microparticles of magnetic field that we have in our nose? Is there something else going on here?
Yeah. Is there an additional benefit that we're getting?
Is there something we're not looking at with the use of the magnet? Because the magnetic portions, the magnetite in our nose, can slow down the air and the particles. Think about that.
That's so interesting. Yeah, I've had people ask me, I'm wearing intake all the time everywhere I go, and people ask me, is there magnets in there? And obviously my answer is yes. And so the question becomes, well, with magnets being this close to like your cranium, your brain, right? Is there potentially any adverse effects, given the fact that we are wearing this on our nose for hours at a time? I don't know if maybe this is your area of expertise necessarily, but I'd love to hear your thoughts on maybe how you feel like if there's a connection as far as any adverse effect goes.
Yeah, and I'm glad you asked that, because if you look at the cochlear implant, the actual implant goes behind the ear so that it conducts sound so people can hear. It's quite a fascinating.
Which is even closer to your
brain.
Brain.
It's like right there behind your ear, implanted like right next to the brain, and it's a fascinating device to help deaf people gain their hearing again. So I was asked this question. I did a lot of research in the medical libraries where I teach. So I teach at Liberty University and Central Michigan University, dug deep into the medical libraries, and I really couldn't find anything. Because I had asked Alex, I said, well, what are the main, ingredients here? What do what are the key, the
makeup of the elements.
What elements are in here? And I really couldn't find anything in there. So hopefully that puts a little bit of a calm to the audience, because they're thinking a magnet, But again, if you're like me and you take a slow nasal breath in, you might feel a snap, crackle, pop, and your nose just open up.
Right.
So I'm going to look more into that because
Okay, please do.
I think that there's something between the magnet on the nose, the magnetic, the magnetite in our sinuses, and here that there's an impact.
Okay. Even as subtle as it may be, right? We still want to know what it is.
Yeah.
And how that changes or benefits or
Yeah.
yeah, that'd be really interesting.
It was really neat. Yeah.
You
But I think we've covered everything. I think, as far as the sizing, you guys did a great job.
Okay.
Does it fit here? But also watch the nostrils, because if you put something on too big, it might take this alar wall and this side of the nose and really stretch it out.
But even then, I feel like it's not designed that way, because I've tested all the sizes.
Yeah.
And when I put on like the L2, and I'm wearing an M1, but if I put on the L2, even if I wash my nose thoroughly, make sure it's dried, those stickies, they don't want to stick for as long just because they're being so pulled out, right? It's not designed to be.
Isn't that something? Look at there you go, the amount of pressure.
Exactly. So there's other signs, not even just related to nasal resistance, because you can't see nasal resistance to the naked eye, but you can obviously see your stickies coming off. So that's another sign that you might be wearing a too big of a size, right?
Yeah.
So I feel like almost everything that we've talked about today, it almost seems like there's like a Goldilocks approach to it, right? It's not too big, not too small, something in the middle.
Yeah.
You don't want too much resistance. You don't want too little resistance. You want the resistance that is designed for your nose to have.
Yeah, but to your point, the size matters, but bigger isn't better.
Right.
Because people think, well, I'm going to really open up my nose. But we have to remember, when you have nasal valve issues or any type of like nasal cycling, people talk about nasal cycling, anything that's kind of a congestive component, you have to remember that resistance is a constant. Resistance is constant regardless of what you do.
Right. And so this is my own personal question, I'm curious, but does resistance increase and decrease when you're doing a certain activity, like aerobic activity? Okay.
Yes. So nasal resistance typically decreases with activity and exercise.
Okay, so mouth tape, right? It's all the buzz right now. Seems like everybody and their mother, father, grandfather, son, everybody's wearing mouth tape. Why? First of all, let's talk about why do we think it's so popular right now, and then maybe also, I want to find out, like, how do you approach it, like, with your studies and everything that you've done?
Yeah.
Are there risks? Are there more benefits?
So I've been asked this question on 4 different podcasts as a guest. Like, what do you think of mouth taping, Dr. Karen? No. Because here's my thinking. And there are some caveats. If your nose works, why are you taping your mouth shut? Think about that. If your nose works efficiently and well, then why do you have to tape your mouth? So I did a study. I looked at 6 different brands. There were different materials. And what was interesting is the public view out there says mouth tape to help you breathe better and sleep better. And they did a few studies, but they only measured the AHI. So the AHI is the apnea hypopnea index. And that is the magic number that all insurance companies and the industry loves.
It's like a credit score for them.
It's like a credit score. It's a credit score for sleep. There you go.
Interesting.
And breathing. But there's a few things you have to understand. That nasal dysfunction, nasal resistance, the last place you're going to see it is in the AHI, the apnea-hypopnea index. And we know from Dr. Howell and his study, published in 2022, that somebody who has more struggles to breathe will have worse sleep apnea. So somebody that has a face that has sleep apnea is different than a face that doesn't have sleep apnea.
Okay.
And it's quite interesting. So to the mouth taping portion, there were only a few studies that looked at AHI to show, yes, it helped with mild sleep apnea. But let's talk about the nervous system. Let's talk about what's happening here. Because you'll see, parasympathetic, sympathetic nervous system, and all these big fancy words around sleep and breathing, right? But here's the problem. When I looked at 6 different brands and materials of mouth taping, it was really interesting to find that the sympathetic tone in the nasal mucosa calmed down. So that portion of mouth taping about calming down the sympathetic nervous system was true. However, there is this big giant nerve. It's the fifth cranial nerve called the trigeminal nerve.
And where's that located?
And that trigeminal nerve is like all over your face.
Okay. So it's like the main
It's like the
nerve
main
that runs
nerve.
the face.
I mean, it's attached to the facial nerve, which is, in your face here, the hypoglossal nerve that's under your chin. I mean, it's connected to a lot.
And it's rooted in the brainstem.
Yeah, it's even connected to the vagus nerve.
Okay.
So the trigeminal nerve, it's broken down into 3 sections: V1, V2, V3. V1 is ophthalmic, your eyes. V2, nasal mucosa. V3 is the mandible. So if you break your face down into thirds,
Ouch.
break it down into, ouch. It's like, V1, V2, V3. Now let's talk about what happens when you put a stimulus on those nerves. So the V2 innervates the top lip. V3 innervates the bottom lip. And what I found is if I put like a tape above the lip and below the lip, nasal resistance would decrease. It didn't really have an impact on the nose. So we can get really scientific, and I talk about this in my first book. It's called the V2, the V3 biofeedback loop. It sounds really fancy, really complicated, but basically what happens here on your lips and your jaw will impact your nasal breathing. So if you put a piece of tape on your lips and you stimulate those nerves, it will go back to your nose. And that's exactly what happened when I looked at rhinomanometry. So it calmed the nose down a little bit, but the nasal resistance increased. So my opinion is this, that if you're trying to retrain yourself to nasal breathe,
Right.
if you have a lip competency issue, say you have an oral appliance in your mouth, because those are pretty big. I mean, you have a vertical height, where your teeth are gapped between the top and bottom. And that can impact, trying to close your mouth. And I'm like, a little vertical piece right here is fine.
Yeah.
But full mouth taping, I am a hard no.
Okay, but what if you
why?
were saying you're retraining, right? What if you're retraining? So would you say that maybe that there are more pros than cons if, like, let's say you're just a chronic mouth breather and you have been most of your life, but now you are trying to retrain yourself to become a nasal breather, and you're wearing intake, or you've gotten surgery on your nose, and now you can breathe better, but just biologically you've been using your mouth to breathe because of your struggles. So would you say maybe that it's worth mouth taping for a period of time, under maybe just a little bit more surveillance of your own?
Yeah, I would. And here's why. When we look at sleep apnea, because they would say, it's going to help sleep apnea and things like that. But here's the clincher, is that sleep apnea also has GERD, G-E-R-D, which is gastroesophageal reflux. And basically a lot of people know what that is. You take Tums or Pepsid. Yeah. So you have this acid reflux. Well, that happens in your sleep. What happens if you have gastric reflux? Or if you get sick in your sleep and your mouth is completely taped shut? Now, my clinical nurse specialist brain goes a little crazy and goes, I worry about aspiration. That's my biggest concern. So, to your question, my recommendation would be do it during the day.
Okay.
Do it during the day. Train yourself during the day. See how you're feeling in the morning. If you absolutely do something at night, like I said, it's on my reels, on my Instagram page. I'm like small, piece right here. Or above the lip, below the lip, that has a flexible material where I call it a straw test.
Okay.
Can you put a straw in your mouth with your mouth taped?
Oh, interesting.
Do you have a little bit of way if you need extra air? Or if you have oral contents, is there a way to get that stuff out?
Right. Yeah, that pretty much eliminates a lot of the risks that would be associated with full mouth tape.
Yeah. Like I said, I worry about the aspiration. That's my biggest concern.
Absolutely. Yeah. No, that makes a lot of sense.
But for training, if you're going to do it during training, you're awake, try it and see how it works. Because going back, the interesting thing is when you look at mouth breathing, we have to flip that script to go from mouth breathing to nasal breathing.
Right.
And you have to reprogram your body. I mean, in fact, when you're congested, it only takes 24 hours for your brain to get rewired to compensate, to go from nasal breathing to mouth breathing so you survive. I mean, it's in Genesis 2:7. God created man and through dust and to breathe through the nostrils. It's that biblical.
Wow. Didn't realize that.
Yeah. I mean, that's my opinion.
Yeah. So do it during the day where you have a
You're
conscientious
monitored.
response. Yeah, you can
Exactly.
monitor it from an active standpoint,
And
not a
what's
passive
really-
standpoint.
And you know your nose is working. Like I said, with intake, I felt like a snap, crackle, pop in my nose. Whether it's the magnetic fields colliding, I don't know.
Like an activation.
Yeah, it's like Wonder Nose activated. It was really
I feel like there should be like a tone. You know how when you turn on your computer with the Mac, you get like every time you put on intake, there should be like a coined sound that happens.
exactly. Can they put that in the chip?
You hit that. Hey, might have to look into it. Q1 2025.
But what's really neat is that when you're nasal breathing well, and it's a slow, like a slow nasal breathe, it feels very cool. You can really feel the coolness come across your nose. I mean, do it with me. If you just sit there and just breathe, feel it just nice and slow. You can feel the coolness come right across. You know you're doing well.
Yeah, it almost feels therapeutic.
It is. The other thing, too, is that, when I look at nasal breathing, I see a lot of posture issues. Like I was saying before, I'll have a patient talk to me and I just see them, just leaning to the opposite direction of the nasal resistance. That's really important because that's how we compensate. So I try to get people that when you're doing breathe right, or not breathe right, but when you're doing intake and you're doing mouth taping, put yourself in like a meditation pose, put your head over your shoulders. That's the way we want to breathe. So put yourself in the most natural position, head over your shoulders, sitting straight up. And when you do that, even when you sit up, because I see you slouching, but if you were to sit up straight and just take a nice slow breath through your nose, you feel it. It's really, it's nose nerd.
Hey,
a nose nerd moment.
So it sounds like what it boils down to is mouth taping. Again, we're in this Goldilocks land where technically, ideally, you're a nose breather and you're not mouth taping because you're naturally breathing through your nose, and you are, not full mouth taping, but maybe you can do it for training purposes during an active state of mind. And then also, if you were going to do a mouth tape, maybe it's just a thin little strip that passes a straw test, so that you can still kind of keep your mouth shut, but you can still release carbon dioxide through the mouth as you exhale, right?
Yeah. And the other thing too is I had a clinician that sent me a picture. A wife was really scared because her husband was
story
on
time.
Yeah, her husband was on CPAP and was mouth taping and got what we call puffy cheeks.
Whoa.
He got cheek puffing, and his cheeks blew up. And she's like, "What is happening?"
Okay.
Well, you had a nasal pillow CPAP machine pushing positive pressure air on a negative pressure breathing system. And he was trying to mouth breathe. So what that told me is that he had really high resistance, and the positive and the negative pressures were like colliding with one another, and the air had nowhere to go.
Yeah.
So he couldn't open his mouth because it was completely taped shut, and he had his cheeks just puffed up.
So did he come up with this on his own? Was he advised to do this? I mean, that sounds scary.
They heard it on social media.
Oh my gosh. The things you hear on social.
And that's why I say when we look at nasal resistance, nasal function, nasal flow, we have got to know what that looks like, because that also is a good monitoring point for all of our different interventions.
Right.
Yeah.
Yeah. We need that baseline understanding.
Yes.
So that we can come up with a plan for our specific noses, right?
Yeah.
Yeah, that's so fascinating. I've met all sorts of doctors in my life, but having like a nose doctor that I personally know, I mean, that's so neat.
Airway, more airway than anything.
Yeah. Well, yeah, I guess that's, a subcategory of airway.
Yeah. And that's what Dr. Vaught and I created. We first defined and developed a term called functional rhinology. Functional rhinology, meaning looking at the function of the nose. Rhinology is everything about the nose.
Mm-hmm.
It's a specialty
Rhino.
in the rhino. It's a specialty in the ENT world.
Mm-hmm.
So we zhushed it up a little bit. Now we have functional rhinology as a subspecialty.
There we go.
Mm-hmm. And it's really looking at how that nose works.
Yeah. Well,
It's
speaking of,
pretty fascinating, isn't it?
absolutely. Yeah. And speaking of how nose works, you touched on it briefly a little bit, but when you asked me to take a deep breath of air through my nose, I'd love to get your insight and take on breathing exercises. Are they also just kind of a fad, or is it something that we should implement in our daily lives to maybe get a benefit that a lot of us are maybe missing out on?
So I think it's coined breath work.
Breath work, okay.
I think that there is a value in any type of intervention. But how do you intervene with the intervention?
Mm-hmm.
What's appropriate? And a dysfunctional nose is never going to react to breath work. And I've seen some things on the internet from non-medical licensed or non-medical trained people that have said, yes, do this. But there's really no scientific,
basis or
literature
evidence
that says, yes, this works. And in the medical world, and I saw this in the EU, in the medical world, they kind of discount some of these things. So when we look at it from a wellness perspective, if we can do breath work to kind of teach us how to calm down, because there is some truth to that. But to say that breath work will help you nasal breathe better, here's the misconception, and I hear this a lot, is that they'll say, we're going to do breath work to activate the parasympathetic nervous system.
And why would we want to activate that?
So the parasympathetic nervous system is kind of your rest, digest. That's the one that calms you down.
Okay.
And it has some vagus nerve. And the vagus nerve we call the wanderer. It's the 10th cranial nerve. It's the wanderer because it starts up in here and it goes all the way to your toes, basically. I mean, it's just like, it's the biggest, longest nerve.
Seems pretty important.
Latin for the wanderer.
Okay.
So it is an
that.
important nerve. But we have to go back to the nose. The nose is sympathetically driven. And this was in 1978. And they looked at the nose itself. We don't activate a parasympathetic nervous system. What happens is the nose is sympathetically driven. Sympathetically driven meaning fight or flight. And what happens is when you withdraw the charge of that sympathetic activity in the nose, such as if you happen to mouth tape, external nasal dilators, then it allows the parasympathetic nervous system to become dominant. So we're withdrawing the charge of one to allow the other one to become dominant. Mm-hmm. So there's a lot of mixed messaging out there. But to your question, I think breath work is amazing because it calms you down. Mm-hmm. I mean, we've been doing this for years in labor and delivery. You have children, right?
Yep.
And didn't they tell your wife to breathe?
Oh, we were doing more than that.
Yeah, see? So right there. I mean, I remember nursing school when we were doing our OBGYN, in the labor and delivery rounds. I remember all the breathing techniques during labor and delivery that we were trying to teach the patients. So it's not a new thing,
Yeah.
I mean, we've been doing it since babies were born.
Right.
I mean, think about it. But I think one thing that's really fascinating is breath holding. Now, Dr. Kern, back in 1978, they looked at anesthetized dogs. And we have what's called chemoreceptors. There's ones for oxygen, and there's ones for carbon dioxide. And they're like little chemical radio antennas. And what was interesting is that 20 seconds of breath holding, nasal resistance increased. So if you're trying to hold your breath for 20 seconds, you're just making things worse, basically.
Yeah.
But what they found is that 30 seconds, it began to drop. So I found it pretty interesting. So when you talk about the breath work, when they say hold your breath for 20 seconds, I'm like, can we pick 10?
Yeah.
Can we pick 10 seconds? Because of what happens with the chemoreceptors and how they're picking up all these changes. And we have to understand that our nasal airflow and how we breathe is kind of like the pH for our body. I mean, how we're breathing really creates balance in our body.
Yep. Especially for the general audience, right?
Yeah.
Kind of want to have start at a safe place. And
Yeah.
and maybe as you continue to develop your breathing and you become more
Yeah.
proficient with it, then
Yeah.
you can start pushing the boundaries a little bit too.
Yeah, I really like the breath work, folks. Again, I talk about this in my book.
Mm-hmm.
There is definitely a place for breath work. Don't get me wrong. It's just how do we implement it? Where do we implement it?
Right.
Do we have the right patient, or are we identifying the right person? Because the other thing too is that breath work isn't really a licensed, regulated type of practice or
Field,
specialty
yeah.
or field. Right. And I think, from a clinical perspective, everything has to be assessed. You
Sure.
have to assess the improvement. So when they work, like some of them worked with me and said, hey, will you work with me? Absolutely. You do breath work. They can come to my office and I'll measure. Is what you're doing working?
Mm-hmm.
Monitor it,
Yeah.
right?
Yeah.
But I think there's value, especially in the sleep world. If someone can teach someone how to, you've had all the sleep surgery done, you've got new different interventions. How is that going to impact your your breathing and breath work? Again, there's a great seat at the table for them in the airway world. I think
Right.
so.
Absolutely. So I guess to tie it all in with breath work, would it be maybe beneficial for someone to wear intake during their breath work exercises?
Absolutely.
Okay.
Absolutely. Do you feel the snap, crackle, pop in your nose when you're doing breath work?
Yeah. I mean, do you think it would optimize maybe the exercise?
Absolutely. Because if
Okay.
you think about the concepts of breath work, and I know enough to be dangerous.
You've got enough degrees on the wall I saw over there, so I'll believe it.
Yeah. But if we look at breath work as a concept,
Mm-hmm.
put intake on, sit up in a yoga position as if you're meditating, and just slow, deep breath. You'll feel even slower than that.
Oh, okay.
I mean, like,
Just really
just
take
nice
it
and
in.
slow, and
Yeah.
just feel the moment, take it in with intake,
Mm.
and you will feel that coolness, that cool air come across your nose. Like I said, it's quite fascinating.
So what you're saying is if I'm wearing intake, I can hang out with the cool kids
Absolutely.
and be accepted.
Because you are a cool kid.
Amen, sister. Let's go.
All right. So let's talk about application
Yeah.
and use.
I see you're not wearing it and I am. Kind of feel left out.
So I'm going to join the party.
All right.
What we have, this is the nice new boxing and new
Ooh.
kit that comes. You can see it.
With the
Share
starter
it.
kit.
Yeah, this is what you're going to see. And you can see, I like the packaging, how it has a different size indents.
Mm-hmm.
Clever. And it comes in two colors,
Yeah,
white and black.
Tells you right there.
Yeah. Now, I have a special request to Mr. Alex.
Okay.
For
Alex,
clear.
listen up.
Alex, can you make these in clear?
Clear. we should work on that. I think that's a good idea.
Just a vanity thing, maybe.
Mm-hmm.
Also, I would love to see these for kids.
Okay. So you're
Alex,
saying
can
that
you do
the
these for kids?
S1 is too big.
It might be for the littles.
Yeah.
Mhm.
Maybe
It
like
could
a SS one. Like, we can go diamond style. You've heard of like diamonds, how they're classified? VVS, VS1,
be. Yeah.
VS1. Very, very, very small.
A VVS one
VVS1. Yeah, we
Yes.
want that VVS.
with a D color.
But let's go to A.
A color. Flawless.
Flawless cut, pristine. Yeah.
So what I liked about the packaging is it comes out in a nice, really, a nice tray, 4 different sizes, and it has a little magnetic
Applicator.
Now, truth be told,
Mhm.
do I use this all the time? No.
Ooh, shame.
Should I? Probably so, because the package insert says so.
I mean, but KPD has oil-free fingertips, so
No.
it's never going to get on her nose.
So, and then you have a little instruction card. So it has a nice little setup here. And then we have a
The
tray
brochure.
of, where's my tray of magnets? We have brochures, and we have our tray of
I
magnets.
think you're holding it in your left hand. Oh, you're talking about the stickies.
Stickies,
Yeah,
AKA the magnets.
the tabs. So the tabs actually don't have any magnetic components in them. There's just the iron. There's just the steel plates.
Yes,
Yeah.
interesting.
So a lot of people
Interesting.
think, the reason I like to bring that up is a lot of people think that you're putting magnets on your skin. And so at no point at all are the magnets ever touching your skin unless you're deliberately taking the dilator and rubbing it on your skin, because they're never going to touch your skin. You have a layer of protection through the tabs, which have the steel tabs, the steel plates in them. And then what happens is you put it on just like that. And so there's a buffer between the magnets and your skin, and you're always going to be magnet free. By the way, these are hypoallergenic and latex free. So if you have concerns about that, we've got you covered.
And tell me about the adhesive properties. As far as like skin integrity, does that bother it? What are your findings as a company?
Yeah, I mean, obviously some people are just going to have really, really sensitive skin no matter what they wear.
Mm-hmm.
They could be wearing Breathe Right. They could be wearing intake breathing. They could be wearing some off-brand company that isn't being mentioned. But of course, you're still going to have people that are going to have some kind of irritation at some point, and that could be due to a lot of different reasons, right? They could have even diet problems that they're having. And so when the adhesive's coming in contact with their skin, that could be something completely unrelated to intake. From what we've noticed and the feedback that we've received from, I mean, at this point, hundreds of thousands of people, is that you clean your nose, you apply it.
I would say, I think I saw like 12 million of these being sold last month. Is that true?
We've sold a lot. I think we're actually out of stock on the white right now. So if you're trying to get white dilators,
the tabs, there was like 12 million tab replacements.
I mean, we're having a shortage right now. Yeah, these things, and that's incredible. Right? It's a testament of what intake does. Intake works. It does make you have an experience life-changing breathing. So let's change your.
So here's the sheet, and I like how this is all done up, and it gives you 30 days.
Yeah, so we have two different starter kits. This is the 30-day, and then we have the 15-day starter kit as well.
I really like that because I tell all of my peoples that come to see me, let's try this. Let's see how you are in 2 weeks. Let's see how you are in 30 days. You know, and we'll talk about this later about sleep apnea, but whenever we did, sleep apnea surgeries, that little magical moment when things kind of calm down after surgery and you start to see an improvement was around like 4 weeks.
Oh, wow.
So I like the 30-day because that gives us really, truly 4 weeks to see how it's working.
Yeah.
So here, we're going to do the tabs. And I didn't take my little tab adhesive. But
The dilator? I can get it.
little I got my dilator.
Oh,
I need that.
The applicator.
The applicator. So, to all the ladies in the house, we love our facial lotions and creams and whatnot. You can't do it around the nose with this. So, do your creams if you have to, but afterwards, use an alcohol pad. So we use alcohol pads. Do you know why we use alcohol pads?
Do tell.
Because it breaks down the bacterial cell walls. That's why you always get a little alcohol before a shot.
Okay. Yeah, and so what you want to do is get rid of that initial layer, right, of any kind of dirt, filth, or oils or anything, so that the stickies can actually stick and do their job.
Exactly. So you can go to any drugstore. I carry a box around of the alcohol wipes because with my rhinomanometer, obviously I have to clean my equipment.
Right.
So I use alcohol pads.
Yeah, and some people, believe it or not, are more sensitive than others to the alcohol and the alcohol wipes. So what we recommend is just soap.
Witch hazel?
Rich hazel, yep. Soap and water. I mean, if you're trying to go at the fundamental basic level, warm water, soap, let it dry for a minute or two, and then do the rest of the application process. But do yourself a favor and clean that nose, because that is the number one thing that we see people struggling with. People will go and buy intake on Amazon, right? And then they'll experience it, and then they have this life-changing breathing moment, and then they write us a review and they say, these didn't stay on. Alex, our CEO, has been wearing intake for 5+ years since the conception of our product. He's never had his stickies or his tabs fall off. And that's because he follows a strict application process, right? It's that simple. Guys, if you want these to stick to your nose, like Dr. Karen said, you have to get rid of your makeup, you have to wash
The
off the
oils,
oils.
yeah.
Just give yourself a chance. Give yourself a chance to breathe better, because you're never going to be able to experience it for longer than, maybe an hour, hour and a half if you don't apply it on correctly, especially if you're going to be doing a workout, going for a bike ride, even a swim. We have swimmers wearing intake breathing, believe it or not.
Ooh,
So,
I got a story about
which we should
swimmers.
talk about
Yeah,
that.
yeah. But so for me, I do this, and the makeup's going to come off. But here.
Oh, you're still a 10 out of 10.
Well, thank you.
You're welcome.
I thought it'd be 11.
I thought about that too.
But so again, my little test, because I want to make sure I have a good placement. What is the maximum benefit that I'm going to get from these? And so coddle maneuver, and we think about the nose. There's 3 vaults to the nose. The first vault is the bony area. Second vault is more cartilaginous here, soft bone. And then we have the fleshy tip right in this area, the third vault. So I tell people that come to my office, coddle maneuver, does this feel better? Not so much for me, so I don't have a nasal valve issue. But then I do the Davidson maneuver. Yeah, that feels good. So what I'm going to do, and I might need help because I don't have a mirror.
I'm more than happy to.
Well, technically, you do this with this, but now you can see my nose. Show me your nostrils. They're pretty equal in size.
Mm-hmm.
And what's really cool is that if you do these on children have round nostrils up until the age of 7.
Oh,
And then they become triangular like we have when we're an adult.
interesting.
Children also have higher nasal resistance than adults. Men have higher nasal resistance than women. So you can see, make sure they're pretty symmetrical. Mm-hmm. Now, what I think is really neat is that these can be customized to your situation. What do I mean by that? So if one side is more collapsed than the other, you want to have more of that impact on that area to really pop it open.
Right.
Because what you don't want to have is still uneven nostrils if you can help it. So here, with the little bumps up.
That's right. Magnets down, guys. Magnets down and the bump up. You'll be able to, if you're looking at the dilator, you'll be able to read the size as you're looking at it, and that's the way you put it on.
So with mine, we do this, and then I just do one side here, clip, and then clip.
Oh, that looks snug.
Can we have a moment?
That looks good on you. Now you're an 11.
I'm a 12. But my point is I bring it more. You can see how Val's is more, it's up a little higher, placed a little higher than mine. That's because for me, coming down closer to the more anterior portion of the nose and popping out this part of the external nasal valve versus the internal nasal valve, for me, it's like maximum relief.
I got to say, that does look really good on you, to be honest.
Y'all, I'm feeling the snap, crackle, pop again.
Okay, there it is. You know what's actually really interesting? I had side quest. I had a makeup artist on our last production that we did. We had her, Miroslav, you were there. We had her try on intake, and it was early in the day, right? So we're like, hey, try this out. She's like, I have a deviated septum. This would be amazing. So we're like, yeah, it would be, of course. So we put it on her, and she has this aha moment. She's like, wow, I can breathe. Okay. So she's breathing better. She's still doing makeup for all the talent that was there. 3-4 hours go by, and we check on her, and we're like, hey, so how's intake? Her voice had changed.
Interesting point. That is true. So
she got her identity back. It was incredible.
That is true. There is a method to that madness.
Yeah. Is there a scientific breakdown that you could help us understand what happened in that phenomenon?
So there's a lot of theory behind it. There's so many different studies, but it's called a velopharyngeal insufficiency.
Whoa.
Really fancy for the back of the throat. When you look at the back of the throat, that section back there, it's called a velopharyngeal area. Pharyngeal meaning pharynx, the throat, that area.
Okay. Yep.
And people that have speech issues could have an insufficiency, meaning when we do rhinomanometry, now we're going to get fancy. I'm going to make you all ENTs by the end of this. But when we look at rhinomanometry and pressures, Pressures are what drive our clinical decisions. Remember that. And even to the providers out there. Pressure is a clinical acumen that we need and drives our decisions. So we have retroglossal, which is behind the nose, and we have retropalatal, behind the palate. And those pressures can change. So to your point about someone's voice changing, when they can breathe better and those pressures change, it goes right down to the vocal cords. That is true.
That's so interesting. Yeah, I mean, you think about it, like, that's fascinating because you're part of your identity, even having confidence, right, is the way you perceive yourself.
Yes.
So if like you have technically lost your voice, you don't feel like talking. Like anytime I have a sore throat, I'm going to minimize my conversations that day, which is going to be a lessened, watered down version of who I am as a person and my personality. Right. So I feel like when you're thinking about intake and how it can change someone's life, obviously we're changing people's breathing.
I'm feeling this. I'm not lying, y'all. This is
hey, we're
really
not paying her to
crazy.
say this. We're not paying her to say this.
It's not a paid endorsement.
Yeah,
but it could be. This is really.
Maybe it should be.
It should be. This is the magnets are speaking.
Let's go. Yeah, we're gonna have to give them names because they've got personalities of their own. But no, what I was trying to say is like I just think it's so cool because not only does it give you life-changing breathing, which is our slogan, I think it also helps you become who you want to be. And I know that sounds cliche and so, whatever, but it's like if I can't speak the way I perceive myself to be as a speaker or even like in conversations with friends, family, XYZ, then I'm starting to become a shell of myself, right? So if I can get my voice back, I'm all of a sudden I'm back to who I was. I have that confidence again. And I can be the person I want to be, the person I perceive to be, and how I perceive others to perceive me, right? And that's important, especially for somebody where maybe they have a job title or an occupation where they need to be seen, heard, right? Maybe it's a job title where
No pressure.
where they're in front of the camera, or somebody who is talking to crowds, or even managing a team, right?
That is so true. Here's another thing too, and I always tell people, if you really want to know how important your nose is, here's a few little things.
Okay.
It affects our swallowing and our taste of food. And if you don't believe me, pinch your nose next time you're eating and see if you can taste your food. You can't.
Oh, this just sparked up an experience I had. I mean, I don't know if you had COVID, but I definitely did.
That was a prime example.
Yeah, and all of a sudden I started saving like hundreds of dollars on food because I stopped eating. I was like, nothing tastes good.
So what's really cool is that when we look at like airflow and people are like, oh, my nose is bigger. A bigger volume nose doesn't always equate to better function because of resistance, nasal resistance, the amount of flow and pressure we have on our nose.
Goldilocks.
And how I always relate to the nose to a hurricane.
Ooh.
This is the best analogy. The nose and nasal resistance is like a hurricane. When the barometric pressure drops, we get more flow, more air, right? But when the barometric pressure increases, the air slows down.
Interesting.
And then the storm diverts.
So it would just be based on your environment, perhaps more so? Like what you're experiencing or doing?
No, I mean, it depends. There are so many variables.
Yeah.
And that's why book number 2 coming out is called The Nose Decoded, Unveiling 60 Functions That Can Transform Your Health. Now, there's 30 out there, but again, I created 60. There's 60 functions, and I broke it down categorically into 5 categories. And one of them is like mental health and how we see ourselves and eating and, behaviors.
Yeah, behavior.
Yeah.
Behavior associated with breathing. It does evolve and it changes, which is, I mean, something that's so subtle and probably best understood from, a psychological standpoint as well. But yeah, I think that's super important, especially if you're somebody maybe who even struggles with self-image and things of that nature, right? That's a whole different.
That's how the nose is even how we define our partners. Think about that. That's one of the behaviors. It's really interesting. You talked about mental health. In 2016, there was a great study where they looked at refractory epilepsy, seizures in patients. And they used EEGs, which were the electrical, kind of like like with your heart when they do EKGs.
Yeah.
This is what we do. It's an EEG. That's kind of what they do for the brain. Look at the brain waves.
Okay.
When you nasal breathe, it's called oscillation waves. So like brain waves. They're flowing, they're good. But as soon as you open your mouth, they drop. Well, when you look at the activity of brain waves as a mouth breather, more depression, more dementia, linked to Alzheimer's. There's a huge component in mental health between the connection of nasal breathing and mental health, specifically in ADHD kids. So in our research and some of the doctors that I work with that are doing rhinomanometry, I brought on psychiatrists for the first time last year.
Oh, wow.
And what's really interesting is these ADHD kids, 100% of them have had a dust allergy so far. So you can see how this all comes together.
Yep.
And that's the story I share with Zach, my son.
Okay, yeah.
So he was an OSA kid.
OSA meaning?
Obstructive sleep apnea.
Gotcha.
Sleep apnea meaning either your airway is not working as well and you have an obstruction and you gasp for air and you wake up.
Oh.
Or you could just have a sensation of air that's not coming through, not coming through the airway as efficient as it should. So what was interesting with Zach is they told me when he was in like toddler Montessori school that he had a speech issue.
That just developed at
like he wasn't saying his consonants and his vowels.
Yeah.
Like he should.
Okay.
And then he was having ear infections. So all the mamas out there with ear infections in your kids, he would get to number 5. And the magic number then was 6 ear infections. You would get ear tubes or PE tubes or pressure equalization tubes to open up those little ears, right? And then it was around, I worked for a home sleep test company. And I was like, let's just see if there's something going on here. And there was. So the next day I said, come here, kid, let me see your tonsils. He had 4+ tonsils. So I called my favorite ENT, who I'd done a lot of OR cases with as a vendor. And I said, do you have an OR date next week? Yep. Are you doing coablation, which is a technology, a radio frequency technology that they use to take out the tonsils? And she said, yes. And I said, okay, I'll see you next week. Actually, we'll see you tomorrow for a pre-op. And we did. But my point is that everybody wanted to put Zach on ADHD medications. The kid couldn't breathe. It wasn't a neurocognitive issue per se, but he couldn't breathe. Now, there can be other issues like this. There's some other physiological issues like the size of part of the brain, the amygdala. So there could be something else. But for the most part, when you look at the number of kids that are diagnosed with ADHD, the last number I saw was like 5.9 million children between the ages of 4 and 17 are diagnosed with ADHD. And of that, about 69% of those children are on medications. And I can tell you one thing, nearly 100% of them did not have their airway function tested.
Yeah. Yeah.
Again, it goes back to the pill concept, It goes back to the pill.
Right. I remember we did the scoliosis thing in school or whatever, but we never did like a nasal breathing thing.
Oh, don't even get me started. Right. We test our hearing in children. We test sight, but we don't test, we don't test their nasal function. Sleep apnea. Yeah. It's all over the internet.
Okay.
It's basically a stop-start in your breathing.
Okay.
If you're obstructed, it blocks your breathing. It blocks the airway. You hold your breath, basically, and then you gasp for air. I mean, that's just...
So it's almost like waking up from a nightmare or something like that.
Almost, yeah.
How does one get it?
Well, gosh, it could be so many different things. It could be genetics. It could be your weight. But even skinny people can have sleep apnea, so you can't blame it on weight all the time.
Okay.
I've seen it. The lady I had in my office with high nasal resistance, moderate OSA, her BMI was like 17.
Jeez.
She was fit. She was a runner.
Yeah.
She was a runner.
That's almost low for a woman, right?
Yeah.
Like too low.
Yeah. I mean, she was on the thin side.
Jeez.
Yeah. So, there's so many different variables. But again, for the most part, it's like, but now nasal resistance, that's a key indicator of OSA. Yeah. When you got too much pressure and not enough flow, and too much resistance in the nose, that's a precursor to sleep apnea.
That's interesting.
And so typically, it's found like snoring. That's the most common thing, snoring, a dry mouth in the morning.
So intake something that could help people with sleep apnea, or do you need something more serious?
Yeah, well, it depends. Typically, they'll do CPAP, the continuous positive.
That's the thing
pressure.
that you put like on your
The
mouth.
big mask on
yeah,
your
yeah,
face.
I've seen that before.
Or there's a nasal pillow.
Okay.
But the industry is trending more for oral appliances, because it's not so invasive. It's non-surgical. I start conservatively.
Mm-hmm.
Can you open up the nose, bring the inflammation down in the airway, and does that help? And it just depends. Now, what's really interesting is that I have data with rhinomanometry and a sleep study from Sleep Image Ring and a nasal dilator. Now, when you look at a sleep study, and even I don't understand them, but what I look for is an AHI, apnea-hypopnea index, and an RDI, a respiratory disturbance index, meaning how is the breathing getting disrupted. What I found is that when I put a dilator on somebody with a spray, the respiratory disturbance index dropped nearly 50%.
Wow.
But the apnea-hypopnea index barely moved. Now, if the industry looked more at the RDI, which is like impacted respiratory, impacted more than the end result of you stopping to breathe, and I say this often, why are we waiting until someone can't breathe to help them breathe?
To start treating it, right?
Why are we not looking at the nostrils and changing that structure mechanically, like with intake, creating this, this kind of a splint to mechanically alter the nasal valve area to allow more air in.
So being more proactive as opposed to reactive.
That's the problem with our medical model. It's, like I said, it's do your exam, create a diagnosis, give it a pill. And if the test isn't attached to a pill for the disease and the diagnosis, then why do the test?
Right.
And then we have reimbursement. So we are a dysfunctional system. We are a disease management system.
Designed to be broken and stay broken.
Yeah.
Absolutely.
I mean, it was interesting. Back in 1983, Walter Cronkite made this is my favorite saying of all time. It was on PBR. It was a public broadcast
radio or
PBR.
something?
Yeah, PBR, public broadcast radio. And he said that we are not, the United States healthcare system is not healthy, is not a system, and it's broken. I mean, it's basically what he said.
It's designed to generate a profit. Yeah.
Exactly. And I could go into a whole health policy conundrum, but
That's a big
when you look at
conversation.
it, the healthcare system is not healthy and it's not a system. It's reactive, not proactive.
Absolutely.
So we're trying to change things. But if you look at the amount of dollars that are spent by lobbyists on Capitol Hill in the billions of dollars, billions.
With a B.
And if we could screen everybody, and this was in my research back 4 years ago, part of my dissertation defense for a health policy change, is that if we could screen everyone's nasal breathing, screen everybody's nasal function, we could save the healthcare industry, just looking at the dental world, $1.67 billion.
Wow.
So what are we waiting for?
It's a huge area of opportunity.
So that's why I'm so passionate about intake, is that this is a non-pharmaceutical, non-surgical. Can we do something to structurally change the nose to improve airflow? The answer is hands down yes.
Yeah, it's a matter of doing it, just like going to the
Yeah.
gym. Right?
Exactly. And if we can improve our breathing, we can improve our tongue posture.
Mm-hmm.
Here's another little fun trick, because people say, well, how are the nose and the tongue connected? I'm like, okay, open your mouth, now try to breathe through your nose and watch where your tongue goes. Open your mouth, try to breathe through your nose.
Oh, breathe through my nose.
Open your mouth, breathe through your nose. Can't do it. Your tongue goes up to your palate, doesn't it?
Yeah. Well, it kind of wants to block the airway going
There you
into
go.
your mouth, into the rest of your body.
Yeah. And what's really interesting is that humans are about the only mammal on the planet that are mouth breathers, except for dogs and cats that have the short noses, which we call brachiocephalic, but they have a short nose. But think about that. Humans, Very rarely dogs and cats. But humans are the only mammal that are constant mouth breathers.
That's fascinating. Did not know that. The more you knows.
The more you know, the more you knows.
All right. So Dr. Karen, again, thank you so much for taking the time to speak with us today. I just had one more question for you. And that's, if you were to sit across from someone who hasn't ever tried intake or maybe is thinking about trying intake, but hasn't been able to quite convince themselves, what's something that maybe you would be able to share from your perspective, given your experience with it personally, and then maybe even like citing something from a medical standpoint that would help them understand why intake might be a good fit for them?
Yeah. So we have to understand the nose is complex. It's its own little organ. And how do you want to keep that nasal flow going?
Mm-hmm.
And at any point in time, you've got nothing to lose. Just start simple. Start conservative. Start non-surgical. You've got nothing to lose and a lot to gain.
Right.
So I look at it this way, that, I practice conservatively. And if you can do a simple Cottle maneuver, Davidson maneuver, is it helping you breathe better? Is it something simple you can do? Cost effective. It's not that expensive.
Right.
It doesn't cost a couple $1,000s like CPAP.
Doesn't set you back weeks.
It doesn't set you back. There's no waiting times.
That's huge.
And it doesn't hurt to experiment.
Right.
You're not doing any harm by changing the airflow to get to your best breathing. And that's the goal. Get to your best breathing. Remember, let's get nosy.
Let's get nosy. Dr. Karen, thank you so much for
It's my absolute pleasure.
taking the
It's a lot of
time.
fun.
It's been a pleasure.
Thank
We'll see you in the next one.